What are some other key outcomes here? Importantly, osimertinib is effective in the brain and can shrink down brain metastases in patients who have advanced disease and also can help to prevent metastases from occurring in the brain in this setting. So, what this figure shows is that what we call central nervous system disease free survival. So, the percentage of patients who are alive and without cancer occurring in the brain. And you could see at 4 years for those who received osimertinib, that percentage was 90% compared to 75% who received placebo. Now, no therapy is without side effects. We view this as primarily a tolerable safety profile. And for those on this presentation who know these side effects, who've experienced them, more commonly was seen diarrhea, nail changes, dry skin, itching. However, just to break down, what low grade does not mean that this is something that doesn't affect quality of life. And for example, a grade 1 diarrhea means increase in stools up to 4 times or just below 4 times per day above your baseline. Grade 2 means 4 to 6 times above baseline. So while we refer to these as low grade and we don't code these as serious, obviously these are side effects that can affect one's quality of life. Now, an important question and point is, do the chances of cancer coming back increase after stopping osimertinib? Now, these are the disease-free survival curves broken down by stage. And what I mark here with this red line is the duration of treatment. Remember, osimertinib was given for 3 years. And the slope of these curves indicate patients who are experiencing a recurrence. And so as each patient experiences a recurrence, that number drops from that 1 at the top of the curve all the way down. And you could see here that particularly for the stage 2 and 3A patients, after osimertinib was stopped, that slope of the curve becomes a lot more steep, indicating a higher rate of cancer recurrences in those who had received Tagrisso. And so for us in the lung cancer community, we were very curious to see why this therapy obviously does benefit disease-free survival. If recurrences increase, will we see a true overall survival benefit for our patients? And luckily enough, earlier this year at ASCO, we did see an overall survival benefit result from this study. And at 5 years, in the primary population of stage 2 and 3A patients, 85% of patients were alive who received Tagrisso compared to 73% who received placebo, translating roughly into a 51% overall survival benefit for osimertinib versus placebo. And just a side note, when I talk about this benefit, this refers to a hazard ratio, which is statistically how we look at benefit for a lot of these therapies. In the total population, including stage 1B, also a similar, very exciting survival benefit for osimertinib or Tagrisso, the trade name, compared to placebo. Now, when broken down by disease stage, you can see here the benefit was most pronounced in those with stage 3A disease, where we saw a nearly 20% numerical increase in survival at 5 years for osimertinib compared to placebo, but there was clear benefit observed across disease stage that was included in this study. So what are some important points and questions for the Adaura trial? So number one, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer. Again, this was by the earlier staging system, but based off the FDA approval, osimertinib can be given for all patients with an EGFR mutated resected non-small cell lung cancer. Importantly, in my opinion, osimertinib does not replace chemotherapy when indicated. This is typically stage 2 and 3 disease because we do know there is a survival benefit there. I think one question that we're still grappling with are more patients truly cured with osimertinib after surgery, or does just a very prolonged delay in recurrences lead to the survival benefit that we've seen? In a practical sense, I don't think it really matters because we know there's an overwhelming clinical benefit and this therapy clearly helps patients and is indicated, but it's more of an academic question here. To that point, how long should patients take osimertinib after surgery? Is 3 years long enough, or should we continue longer? And on the flip side, are there some patients who are cured with just surgery and don't need osimertinib? And I think lastly, and this is an important point, is can this approach be used for patients with other driver mutations, such as ALK, RET, ROS1? And I think there are key factors here. Number one, you must know that understand there's a lack of data here. So everything we would do in this scenario is extrapolating from Adaura. But there are key attributes that drugs, I think, need to have to be considered here. And that includes very effective therapies that have a tolerable safety profile, where one could take this for 3+ years. And the drugs must have an ability to get into the brain. And as Dr. Desai mentioned earlier, financial toxicity and insurance coverage, very important here as well, especially since strictly speaking, this is not an indication that's yet FDA approved. So, what are some ongoing trials addressing osimertinib? Some of these questions. So, for duration of therapy, there's the phase 2 Target trial, which is looking at 5 years of osimertinib for stage 2 and 3B patients. And on the right is the phase 3 Adaura 2 trial, which is looking at osimertinib in earlier stage 1A2 and A3 patients.